Good morning, everyone. Today, I'll be trying to clarify an abnormal variant of TOF, which we encountered over the last few years in our center. So, other than the routine morphology of TOF, we know that the coexisting anomalies and the variants in TOF can have a significant implication for surgical management. And also, the advanced cardiac imaging provides an excellent visualization of these variations. So in 2011, we encountered an unusual case. This case was a case of a TOF with severe pulmonary stenosis with a right aortic arch and had a short segment LPA atresia. But there was a significant mid-RPA stenosis, as we know, which is not very common in TOF. Here we encountered that the aorta was quite more posteriorly located, and there was a significant stenosis in the mid-RPA stenosis. And overall, we decided that it was logical to do a Lecompton maneuver and bring the RPA anteriorly to relieve the RPA stenosis. Over the next few years, we saw that similar anatomy and similar morphology was seen in few more cases where the commitment of, they were all cases of aorta with right aortic arch, but the commitment of aorta to LV was much more compared to the routine TOF, and the location of the aorta was posterior as compared to a routine angiogram, as we can see on the extreme right side of the screen. And also the crossed PA anatomy was also visualized. So as we looked into the 3D imaging of these patients, if we look these patients from the heart from the head end of the side, we found that the orientation of the ascending aorta gave an impression of an S with taking two different curves, and hence we named it so. However, we did not find any similar description in the literature. Hence, in this retrospective study, we sought to clarify the anatomy of this S-shaped ascending aorta with TOF. We wanted to clarify the morphological features and also to compare them with normally oriented ascending aorta. We included TOF patients with S-shaping aorta who had a good quality imaging and compared them with controls. Standard echocardiographic measurements and analysis was done, and along with demographic data, but our primary focus was an ECG gated CT angiography for the study, and if angiograms were available. The analysis was independently done both by cardiac radiologists and pediatric cardiologists, and we used multiplanar reformatting and volume rendering techniques. We also did virtual dissection on Horo's DICOM viewer. We had a preset morphological variables that we had to look into the study. Other than the standard parameters, we defined the shape of the aorta and the measurements of aorta and pulmonary arteries in detail based on these morphological assessment parameters. Descriptive statistics was done and appropriate tests were used for comparison. So before we move on to the study, we would like to focus on one case. Here we see that this on the right side is a normal TOF where the overriding is nearly about 50%. But on the left is our index case, which is showing that the commitment of aorta is much more towards the LV. While imaging, we also realized that it was very difficult to open up the pulmonary outflow. It seemed that it was very anterior. As we did the suprasternal short axis, we see that the significant mid-stenosis RPA stenosis was also found. We moved into the intracardiac anatomy of the heart, and then we saw that the location of aorta is much more leftwards. The commitment of it is more towards LV. And then we see the crossed PAs arising anteriorly. And then finally, the right arch taking turn. So this is explaining the S-shaped aorta, which is seen in this subset of patients. We further analyzing, we saw that on multiplanar imaging, we see that RPA is compressed anterior-posteriorly, making it narrow between ascending aorta anteriorly and descending aorta posteriorly along with the trachea. So the anteroposterior diameter was quite reduced, whereas the superior inferior diameter was preserved. Standard measurements were taken for a tortuous vessel using a double oblique technique. And we also measured the tortuosity index, comparing the shortest distance and the curved distance of the ascending aorta. We wanted to see the position of aorta, so we took the measurement of the mid-ascending aorta from the sternum and also the sternovertebral distance. So we encountered 16 patients in our database. 14 patients had right aortic arch, and two other patients had, one of them had left aortic arch and double aortic arch. Some other cases were also included, which we haven't found later on, which we haven't included in the present analysis. Segment analysis, all of them had normal segment analysis, had single malaligned outlet PST. One, except one, all of them had aortomitral continuity, and all of them had pulmonary stenosis, except one. So importantly, two patients, except two patients, all of them had right aortic arch, and except two patients, all of them had RPS stenosis, which was also our initial point to be looked into. Hence, we compared our cases of TOF with right aortic arch to controls, which were also right aortic arch TOF, but normal ascending aorta. So we saw that the aortic override degree was much lesser compared to our control group. And also the position of the aorta was much posterior, which can be seen here as the sternoaortic distance was much more posterior, whereas the sternovertebral distance remained the same. The aortic diameter, especially at the mid-ascending aortic diameter, was dilated, and the ascending aortic length remained same in whatever way we measured, and even the tortuosity of the ascending aorta was similar to the controls. Now, the position of normal in a TOF, in a routine TOF case, would be aorta would be posterior and right here, but there was a variation seen in a good number of patients, with about 5 patients showing different aorto-great artery relationship, and about 3 patients showing even aorta posterior to pulmonary artery, and some of them even aorta left and posterior. As we had initially hypothesized, the RPA compression was significant in the study group, and also the percentage of crossed PA was very high. So overall, summarizing, the degree of aortic override was quite lesser in our patients. The ascending aorta was dilated compared to controls. The position of aorta was much more posterior, and RPA compression and cross pulmonary artery stenosis was significantly higher proportion in the study group. Some other abnormalities which we found were LPA ostial stenosis and aortic branching abnormalities. Surgical data was available for 5 patients, out of which 1 patient, which we discussed, had undergone Lecomte maneuver. And 2 of these patients had very small PAs to begin with, so they underwent central shunt. One of their patients with double aortic arch did not have RPA compression, again reiterating the fact that the right-sided aortic arch is actually causing the RPA compression. So why no similar description in the literature? So we moved behind the literature and saw another similar case where it was a right aortic arch, but here the compression was in the trachea. So we believe that it's not uncommon, but possibly an under-recognized entity. Similarly, the location of pulmonary, the great artery relationship can be different. And in this huge series of—
Can you summarize? Your time is over.
Yes, ma'am, I'm just finishing. Autopsy studies, the difference, the range of aortic override can be different. So we would like to, the embryological basis could be that the aorta is abnormally rotated, and that is why we also have cross PAs and RPS stenosis. The surgical implication, we may have to cater individually to each patient and may require techniques like Lecomte maneuver and aortic suspension. We are underway doing our genetic testing for the patient, and also some complete surgical correlations lacking, although we are on the way to find out the details. So I would conclude saying that it is not an uncommon, but an under-recognized variant. An S-shaped diabetic aorta is the cause in our cases, which causes significant RPA compression and needs addressing and recognition. And also we may need to modify the surgical technique. An unusually oriented ascending aorta should on an echo where we are unable to see the RVOT properly may give us a clue to this variant. Thank you.